for coming, and I appreciate Cindy's help putting this together. So we put together a series of 4 lectures on chronic thromboembolic pulmonary hypertension, or what we call CTEPH, and mine is the first lecture, and this is meant to be an overview. So I'm going to touch on diagnosis and definition of CTEPH, how and whom we screen for CTEPH, how we confirm the diagnosis, a general approach to treatment, because there's going to be separate lectures dedicated to that, but I'm going to show you some cool CAT scans. And so surgery, BPA, which is a kind of new sexy thing on the block, so we'll talk a little bit about that, medical treatment. So these are the objectives. So kind of a lot packed into a short period of time, but again, it is meant to be an overview, and then I can answer questions. Okay, so some myths about CTEPH. Number 1, only patients diagnosed with a PE get CTEPH, and I'll tell you that's not true. Number 2, I see a lot of patients with pulmonary hypertension, but doubt any of them have CTEPH. That's also not true. My pulmonary hypertension patient had a CTA with no acute PE, so CTEPH was ruled out. We'll talk a little bit about that. And my patient with CTEPH is stable in medical therapy, so that should be enough for now. So that's also not true. Okay, so let's start with a definition. So pulmonary hypertension is a purely hemodynamic entity. So when someone says pulmonary hypertension, all they mean is that someone did a right heart catheterization and they got a mean pulmonary pressure above 20 millimeters of mercury, and that's a change from in the last several years. The left-sided pressures were normal, so wedge was less than 15, and there was a elevation in pulmonary vascular resistance more than 3 Wood units. There are different groups of pulmonary hypertension. Group 1 is what we call PAH, and that's a big group of patients that consists of idiopathic disease, familial disease, and then we see patients who have connective tissue disease like lupus, congenital heart disease, so people who had ASD, HIV. Some of the medications called pulmonary so fen-phen is a big famous one, liver failure. Group 2 is something that I call sort of sick left heart. It's pulmonary venous hypertension. So these are patients most frequently who have problems with either pumping, so they decrease the EF heart failure, or more likely diastolic heart failure. In the units, I think we often also see people who have long-standing valvular disease. Group 3 pulmonary hypertension is chronic lung disease. So these are your patients with COPD. We see a lot of interstitial lung disease in IHVI. You guys probably see them as well. So these are the sort of the big 2 categories. Group 4 is what we're going to talk about, chronic clots. In addition to CTEPH, pulmonary artery tumors like sarcomas also falls into that category. And group 5 is miscellaneous, and that's a big group. We often see patients with sarcoidosis. Renal failure is another big one, but other things like sickle cell disease fall into that category. So today we're talking about group 4 pulmonary hypertension, or CTEPH. So let's talk about acute PE and CTEPH. So every year in the US, about 500,000 people are diagnosed with acute PE. So incidence is about 100 people per 100,000, and 30 to 50% of them are submassive or massive. However, acute PE often can be silent as well. So one of the myths that I already mentioned, can patients who have CTEPH not have a history of acute PE? And the answer is yes. So 30 to 50% of patients who are coming in with a diagnosis of CTEPH have no previous diagnosis of either PE or DVT. Doesn't mean that they didn't have it. They may not have been diagnosed, but this is the statistics right now. Cumulative incidence of CTEPH post-PE in the studies has been anywhere between 0.57 to 8.8% at about 2 years out. So if you sort of combine all of the studies together, and there are not a lot of patients in those studies, we settled on a number somewhere between 2 to 3%. So if you have a PE at two-year mark, especially if you have symptoms, the incidence of CTEPH is about 2 to 3%. So why do some clots fail to resolve? It's really poorly understood. Inflammation seems to play a big role of it in it. So in patients who have CTEPH, increased inflammatory cytokines and inflammatory markers have been definitely documented. So things like CRP, hypercoagulability plays a big role, but not the hypercoagulability that we think of when someone presents with an acute PE, but things more like malignancy, some abnormalities in fibrinogen, platelet activation pathways, which are often affected by thyroid disease and splenectomy, and some inherited disorders as well. There is some postulation that impaired angiogenesis also has something to do with this, and just small vessel disease in the lungs, so small pulmonary arterioles. If you look at all of the patients who have a PE, you will see that a lot of patients actually have dyspnea after a diagnosis of PE. Not all of them have CTEPH, or actually only a small portion of them will have CTEPH. There are different reasons why people have dyspnea after PE. Some of them may have chronic clots but not have pulmonary hypertension. In some patients, we do not diagnose any chronic clots or pulmonary hypertension, but there is definitely, if you do cardiopulmonary stress test, there is definitely measurable limitations in that function. And a lot of patients have actually symptoms without necessarily something that we can account for. So we clearly do not understand this disease very, very well. So what are the risks for chronic thromboembolic pulmonary hypertension? So on the left, you see a big table that comes from the sort of this big article that was published in the New England Journal of Medicine in 2004 that that lists all of the known factors at that time. But I pulled out some of them that seem to be most pertinent. So clot burden seems to have a very high correlation with development of CTEPH. So submassive or massive PE. If someone has significant pulmonary hypertension at the time of presentation with acute PE, so systolic pulmonary pressure more than 50, either extremes of age, either older or younger age, when you have recurrent PE or venous thromboembolic disease, and hypercoagulability. So the process of CTEPH is development of CTEPH is there are two portions to them. One of them is the clots. So if you look at this, the histopathology clots slides or photographs, this is the persistent clot that has organized. So if you look at the drawing on the left side, you'll see there is a persistent macrovascular and microvascular obstruction that happens in some vessels. So the clots don't resolve and they sit there. However, there is the secondary process that we call persistent vasoconstrictor response. So even in the vessels that are not affected by clots, there is this constriction in the vasculature. And why that happens is not very well understood. It is thought to be caused by kind of regional hypoxemia and also some local pulmonary arterial just shear stress by the vessels that actually have clots in them. So you'll see that there is sort of this clots, and then there is the secondary arteriopathy. And so as a result, what happens in the lung itself, you eventually are going to have increased pulmonary vascular resistance, both due to this micro and macrovascular thrombi and the small vessel arteriopathy. And at the end, just like in other causes of pulmonary hypertension or in other cases of pulmonary hypertension, right side of the heart is going to be under stress and it's going to fail. So these patients with CTEPH, if it's not treated, are going to die of right heart failure. So if we discuss this untreated CTEPH and see how patients do long term, the biggest factor that dictates whether people do well or they don't do well is how high their pulmonary pressures are. And what you see here with these different curves is the how high the pulmonary pressures are. So the red curve is pulmonary pressures more than 50. And so patients who come in with CTEPH with mean pulmonary pressure more than 50 have about 80% mortality in 2 years if untreated. So this is worse than most common causes of cancer, so breast cancer or lung cancer. So it's a very, very, very morbid disease. And again, lower pressures associated with less significant mortality, but still significant morbidity. So what is the clinical presentation of patients with CTEPH? Unfortunately, symptoms are non-specific and pretty insidious of onset. Average time of onset of symptoms to diagnosis is 2 to 3 years. So you imagine these patients go from a physician to a physician often with the complaints of shortness of breath. In one study, about 45% of patients saw 4 or more doctors before they got correctly diagnosed with CTEPH. So the symptoms are exertional dyspnea, so with a gradual decrease in exercise tolerance. People can have palpitations, lightheadedness, fatigue, bilateral lower extremity and abdominal swelling. So these are the things that are developed that you see when someone develops right heart failure. But also some of the symptoms that people report are actually due to just increase in pulmonary artery size. So non-productive cough, hoarseness, and also pleuritic chest pain. So what is the evaluation for CTEPH? So if people come in, so it's easier when someone comes in and they have a history of PE. So if someone has a persistent shortness of breath, at 6 months out after diagnosis of PE, they need to be worked up for CTEPH. If someone presents and they have pulmonary hypertension, this pulmonary hypertension is confirmed by right heart catheterization, you have to rule out CTEPH, and I'll show you why. So traditionally, VQ scans is the initial test that you do after you have these 2 scenarios. If the VQ scan is normal, then CTEPH is ruled out. Unfortunately, most of the VQ scans that we get are not normal. They're read either as low probability or intermediate probability, and so it becomes less helpful. So when you are in that situation, then we do more workup. So a CTEPH patient usually gets a number of tests. So they have a chest X-ray sometime along the line because they've had shortness of breath. They often get pulmonary function tests. At some point, someone orders an echocardiogram, and that echocardiogram is usually abnormal. And then, someone orders a CT angiogram, and that may or may not show something because, again, CT angiogram is good for acute PEs, acute and central PEs, but not distal PEs. And then eventually that leads to right heart catheterization. As I mentioned, theoretically, what should happen is the VQ scan should come really early in this diagnostic workup, but it doesn't happen very frequently like that. But so VQ scan, we do dual energy CTs here, and I'll show you some cool images of that. And then a patient will get a pulmonary angiography, and then if they're older and they have a sort of risk factors for coronary artery disease, and you consider them for surgery, then you need to do cardiac workup to risk stratify them. So what are the goals of diagnostic evaluation? So we want to confirm presence of CTEPH. We want to obtain the hemodynamics, because I already mentioned that hemodynamics are going to help you prognosticate what happens if they get treated and how they get treated. You want to have an anatomic data, so we will see some of that. You want to correlate anatomic and hemodynamic data. So if you have very high pulmonary pressure, but you have very little clot, that clot is probably not responsible for this hemodynamic abnormalities. And so doing something like a CTEPH surgery on someone who has very significant pulmonary hypertension and very, very little clot is going to get you into a whole lot of trouble. And then evaluate comorbidities. But really what we want to do is we want to determine if we have a CTEPH patient, are they an operative candidate? And then we also want to try to predict this hemodynamic outcomes, because hemodynamic outcomes, or how much you are able to lower the pulmonary pressures and pulmonary vascular resistance after intervention, will dictate how well patients do. So some cool pictures. People usually like pictures. So this is an echo, normal echo on your left, abnormal echo on your right. So this is the echo that shows a big right ventricle. Very often we can do it at bedside. We also do this very cool three-dimensional echoes in HVI that can actually calculate like ejection fraction of the right ventricle. So this is something that's very cool, and we use it for a lot of patients with pulmonary hypertension. VQ scans. So VQ scans can be helpful and not helpful. The problem with VQ scans is there are very few people who do them and read them every day on an everyday basis. We do have a couple of the nuclear medicine radiologists who do read VQ scans. If you go out into community, they're very infrequently obtained, and so you have to be very, very careful when you rely just on the interpretation of the ventilation perfusion scan. So it gives you some physiological information, but it really does not give you information on whether, on what vessels are affected by the disease and the extent of the clots. And the VQ scans can also be abnormal, not only in CTEPH, but in other processes, like, if you have a arteritis of large pulmonary vessels, so if you have PVOD, or if you have pulmonary artery sarcoma. So it's a test with a lot of limitations. It definitely requires operator, someone who is really good at reading them. Otherwise, you have to take them with a grain of salt. So let's do some of the sort of cool scans for acute PE. So you have to be careful when reading CAT scans. Acute PEs have a number of characteristics that we usually look for that are not there for chronic PEs. So with acute PEs, we usually see this intraluminal filling defect with this abrupt cutoff, as you see with the like yellow arrow. The blue arrow shows you that the clot is sort of in the middle of the vessels. It's not on the walls of the vessels. And you don't really see any blood flowing through the clot. So that's something that happens with chronic clots when you get this new lumens. You can see the right heart strain if it's an acute clot, and that can be helpful. And sometimes you can see if the blood doesn't flow through the acute PE, you can actually see an infarct in the parenchyma. So what about chronic clots? So very different picture. So again, you have to really look at the scans, or ask for help from a good radiologist, because with the acute clot, management is going to be very different than in a chronic clot. And when someone has CTEPH and they come in with the sort of acute decompensation, you have to be very careful, because it may be an acute decompensation from right heart failure, not because they had an acute PE. And so you want to treat them differently. So here, red arrows, A and B, shows this partial eccentric clot. So you can see it's kind of pulled to the side of the vessel. You get those bands. So the letter C will show you this kind of gray line. So this is what we call a band. And then the D is a vessel that's dilated. We call it poststenotic dilation, because right before this dilation, you'll see this band of the vessel being constricted. And the reason that it's constricted is because there is a clot in there. A huge pulmonary artery. So when you see a humongous pulmonary artery, that normally is not an acute clot, because it takes time for pulmonary artery to dilate. And then you can see this mosaicism in the parenchyma, so that's where the little stars are, and that's because these parts of the lungs are not being perfused, and they're not being perfused not because there is an acute clot, but because there is a bunch of chronic clots. So I wrote down some things for the part of the audience that looks at the CAT scans. But these are the things that you want to look at. So in chronic PEs, clot is usually retracted, and it's usually along the wall, not in the middle. You're looking at the enlarged pulmonary artery, usually more than 3 centimeters is very big. Usually more than 1 centimeter is pretty big as well, but more than 3 centimeters is definitely very big. You're looking for bronchial artery hypertrophy, so I'll show you some examples of that. It takes a while for bronchial arteries to hypertrophy, and you can see it on the CT scan. You're looking at this lobar segmental artery size discrepancy. You can get calcifications of pulmonary arteries. Again, that does not happen overnight, and this mosaicism. And then you can also look at the heart on a CT scan. It's not as good as an echo, but it'll give you an idea of the chronic right heart strain. So some more kind of cool pictures. So the picture in the middle is what we call bronchial artery hypertrophy. So usually you should not be seeing bronchial arteries, that they should not be that visible on a CT scan. This eccentric clot, which is along the sides of the pulmonary artery, so not in the middle. So that's on your right, I guess, and the left a little bit, but on the right as well. On the CT scan in the middle, on the bottom, you see complete absence of vasculature. So when you don't see any vessels, that's a bad sign. That's usually not an acute clot. Okay, so CT angiogram is super helpful, but it has to be done right. The contrast has to be timed to detect some of the chronic abnormalities. So if you're worried about CTEPH, you really need to talk to the radiologist. So they don't only time the contrast for acute clots, but also for chronic clots, and they look for these other signs of the CTEPH. The other thing that CT angiogram does not do, it's not very good about detecting clots in the distal disease, and that's why a CT angiogram alone does not rule out CTEPH. Okay, so what do we do here? We have a cool new diagnostic modality, which is called dual energy CTA, or we call them DECT. Dual energy CTA is something that appears to be sort of a one-step assessment. So it is a CT scan, and it is performed like a CT angiogram, but again, the contrast is timed a bit differently. So you can see the further out in the periphery as far as the vessels are concerned. And then you get this very cool perfusion maps. And these perfusion maps can give you clear defects where the lung is not being perfused. So it's sort of like combining a CT angiogram and a VQ scan. So there is a dual energy CT in the heart, in the main radiology, and there is one that's going to be put into the HVI. So for many patients who come in who are sort of, you don't think they have an acute PE, they may have a CTEPH, getting a dual energy CTA can be super helpful. And so we can order them here. Okay, so what do we do after that? So we think someone has a CTEPH. This is when we ask for help from our interventional radiologist. And so we have one interventional radiologist who does a lot of work on CTEPH patients. So that's Dr. Boutros, and also interventional cardiologist, and that's Dr. Tirani, to get something we call selective pulmonary angiogram. And selective pulmonary angiograms are different from a regular pulmonary angiogram, where you sort of shoot a dye from the big vessels and get a picture of the central pulmonary arteries. Selective pulmonary angiograms evaluate every segment and every subsegment of the pulmonary tree. So it's very cool. And this is all of the segments that are listed on the right and the left. There are quite a lot of them, and obviously there are many more subsegments. So catheter pulmonary angiogram is extremely helpful, and there is you can see the abnormalities in pulmonary arteries better than on most CT scans. But again, the dual energy CT scan can come close, especially in the segmental vessels. But what you can see here with the errors, there is different types of lesions. So there is something called a ring lesion in the pulmonary artery. You shouldn't have this stenosis. you see something called webs on the picture, which is picture C. There is you can see that there is very little blood flow that's going into the pulmonary artery, so we call it a subtotal occlusion. And on the picture D, there is a total occlusion, so there is no flow at all. And then you also get this tortuous vessels in CTEPH. So you see they're not nice and straight. They kind of look like a little ribbon. So all of these are signs of CTEPH and pulmonary angiogram. So you diagnose your CTEPH. What do you do after that? So you want to have a multidisciplinary team. So you want to have a team of people that can assess different parts of the disease. So a surgeon obviously is very important. You want to have a medicine physician, so a cardiologist and pulmonologist. You know, we're lucky to have a team of both. You want to have an interventional cardiologist or interventional radiologist. So these are the people who can do a right heart catheterization, but also can do balloon pulmonary angioplasty. And obviously you want to have a very good imaging physician who is experienced in reading studies of CTEPH patients. But the first thing and so we assembled a team a couple of years ago, and with Dr. Tang coming here, have been able to do some of the PTE surgeries, so which is great. But the first thing that you do, and this is what we do every month to every 2 months, is we present patients, and you want to know whether a patient has an operable disease. Patients who have operable disease with CTEPH have by far the best prognosis out of all of the patients with pulmonary hypertension. So if you can get the clot out, and if you can get it out successfully, and if you can get those pulmonary pressures and pulmonary vascular resistance to normal, these people have great survival and really great outcomes. Their quality of life is significantly improved. So this is the first question: are they operable? The other question is, if they are not operable, can we do something for them? So for patients who have distal disease, we often can offer them balloon pulmonary angioplasty. And for patients, and often they can also get medications. And for patients who are not candidates for either, for a variety of reasons, we can offer them medications. So let's talk a little bit more about sort of each one of them. So who is operable? So there are 3 things to consider when you think about patients with CTEPH. Number one, are they accessible by surgery? So usually, and I'll show you some examples of that. I already mentioned, is the clot responsible for hemodynamic impairment? So if you have very little clot but bad pulmonary hypertension, this patient should not go to surgery, because they'll probably die if you try to pull them out, because their right heart will not be able to handle it. And can the patient tolerate the procedure? And that's more of a loaded question, because if you have someone who is extremely frail, or they have active malignancy, they may be a surgical candidate but not be a medical candidate. So you sort of have to look at the patient as a whole. So pulmonary thromboendarterectomy, so PTE, so that's the procedure we do for CTEPH patients who are surgical candidate, both surgically and medically, generally reduces pulmonary vascular resistance more than medical therapy. Again, the goal is to reduce the pressures and resistance into a normal range. It is the only thing that offers a chance of cure for these patients. And as I said, it improves survival significantly. So at 3 years, patients who were candidates for surgery and who received surgery had an 89% survival versus 70% survival with medical therapy. And they were all comers. So these are not patients just with severe disease. So some of these patients had mild disease. But if you look at patients with severe disease, the difference is so much greater. So is this clot accessible by surgery? So these are different clots. These are different what we call levels of clots. So level 1 is where you have clots in major vessels. So this is not acute clot. This is all chronic clot that if you touch it, it feels hard. It's calcified. Level 2, the same thing. It's accessible by surgery. You don't have a clot in major pulmonary arteries, but you have, or sometimes you do, but it also extends into the lobar and segmental vessels. Level 3 is you do not have clot centrally, you do not have clot in lobar vessels, but you have clot in segmental and subsegmental vessels. This is surgery which is difficult to do, and it requires significant surgical expertise. And level 4 is what we have with very, 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 very distal disease. There is very limited data that operating on patients with level 4 disease is successful. Usually those patients require either balloon pulmonary angioplasty, or they require balloon pulmonary angioplasty and medications or medications. But level 1, 2, and 3 disease generally are considered accessible by surgery. So PTE in a nutshell, so it is a relatively safe procedure. Again, you have to have appropriate candidate selection. Mortality is about 2.2% in hospital mortality, and that data comes from the major center in the United States, UCSD, that has done thousands of surgeries. The rest of the centers in the United States are sort of far behind in their experience, but there are more and more centers that are developing all over the United States. And usually most of the teams go to UCSD to do some training. It's about 4.7% in European centers of excellence. And again, there are a variety of reasons why the data may be what it is. Risk factors for poor outcomes. There are a number of risk factors. I already mentioned the high pulmonary pressures and high pulmonary vascular resistance in the absence of the clot burden. When you have someone in decompensated heart failure, right heart failure, usually there is this association with increased perioperative mortality. So we try to get people sort of optimized for surgery if we have time. So they need to be well diuresed. Sometimes we would use medications to help us along. Coronary artery disease increases in hospital mortality 5 times, and 1-year mortality 3 times. So that usually those patients, and that's why we do cardiac workup on older patients. So people who have central clot usually do better. I already mentioned that. And I already mentioned that inadequate hemodynamic response is bad. So if you do surgery and the pulmonary pressures and pulmonary vascular resistance do not decrease to basically normal levels, those patients have by much higher in-hospital mortality than in patients that do. So you can see like 10% in-hospital mortality. So again, you have to choose your patient very well. You have to have an excellent surgeon. You have to have a team of people who take care of those patients postoperatively. And I think we have all of that. Okay, some other things: obesity, taller height, prior sternotomy do not seem to be associated with increased mortality, and age more than 70 increases length of stay, but not mortality. Okay, let's talk about balloon pulmonary angioplasty. So it's very cool. Again, it's a procedure where in our hospital, Dr. Boutros and Dr. Tirani performed this procedure. They went to Japan to learn how to do it because centers in Japan have by far the greatest experience with this procedure worldwide. So no absolute contraindication except for contrast allergy, because you do need contrast, and severe renal insufficiency. Again, as I mentioned, it's indicated for inoperable disease, distal disease. Sometimes patients who had a PTE done, but then they have some very distal disease, they may benefit from this balloon pulmonary angioplasty. And what they do basically is they identify where the defects are. They put in a small flexible wire through the clot. Again, you cannot put a wire through a completely occluded vessel, or the vessel which is tortuous. So you have to choose your patients very well. A balloon goes over the wire and then it gets inflated. We usually do very low level of inflation the first time around to gently dilate narrowings, and then people come back for another session and usually another session and another session. So every patient would undergo somewhere between 2 to 6 sessions on all of the vessels that are BPA candidate vessels. So what are the risks? So in the European literature and some of the US literature, 30-day mortality was recorded at about 2% because of the severe perfusion injury. If you look at Japanese data, and that's the approach we use, the 30-day mortality was less than 0.05%. And the reason for that, again, that they use the approach that I described rather than going and dilating a vessel right away pretty quickly. Again, complications usually depend on technique. Reperfusion injury has been reported in about 50 to 60% of cases. We have not had any reperfusion injury with our BPA cases so far. Bleeding, again, if you over-distend the vessel, if you poke a wire through it, can give you bleeding. And usually, when you see that technique being done and patient starts coughing, that's like a big tip off that your wire is not where it's supposed to be. So again, it's a learning curve for our program, but so far we've done about I think somewhere between 10 to 15 BPA procedures, close to 15 BPA procedures, and so far we've had no complications. Okay, so let's talk about the medical therapy over a couple of slides, and then we can do questions. So the only medication that has been approved by FDA for treatment of chronic thromboembolic pulmonary hypertension is something called riociguat. So riociguat works on nitric oxide pathway. So it's a cyclic GNC stimulator. It was approved for patients who have functional class 2 and 3 symptoms, and the only patients that were enrolled in the trial are patients who had inoperable disease, again, either surgically or medically inoperable, or patients who had a residual disease after a PTE surgery. So this trial included 261 patients. If you look at the patients who were enrolled in the trial was done primarily in Europe. So most of the patients were Caucasian. You can see there are a smattering of other races that were represented, but not as uniform representation as you usually have with the US trials. Females and males about equally represented, and 70% of patients had inoperable disease, and then most patients had a functional class 3 symptoms. And you can see that patients in both groups walked about 315 meters in 6 minutes. Just for reference, if you take a patient who is healthy, they should walk about 650 meters, so about a half of what people normally walk. And what the trial showed is patients who got riociguat had about 40-meter improvement. Their pulmonary vascular resistance dropped down significantly. Their BNP levels dropped down significantly, and more patients moved into their better functional class than the patients who got a placebo. So all in all, it definitely was a positive trial across many endpoints. There was another trial of a drug called macitentan, which we use for pulmonary hypertension, that was just published a couple of years ago. There were about 190 patients there, and again, that trial looked at the drop in pulmonary vascular resistance in patients who either got macitentan or placebo, and it was a positive trial, but the FDA wanted more data. So that medication did not get approved for CTEPH. Okay, so I mentioned already we have a CTEPH program in the hospital. Sort of it's been one of my goals is to have a CTEPH program at Inova, and so it took a lot of hard work on many people's parts. And so I want to acknowledge a lot of people that have made it possible. So surgical teams, our NPs, our PAs, now the nurses on CVICU, CVSD, and CTU North, where all these patients are have started to come. These are the people who are sort of are going to be on front lines taking care of these patients. So thank you for that. We have an excellent PH pharmacist, Aaron Bagnola, who's been really, I don't know what I would do without him in taking care of PH patients. And so he's been involved in the CTEPH program as well. Chris King and Mitch Sotka, you guys probably know, obviously both of those guys are a central part of the program. I already mentioned our BPA team. We have a CTEPH staff that they both on the RN side and the as well as the PA side. So Nikki, you guys have met her, and Shanna is our go-to CTEPH coordinator in our clinic. And then, as I mentioned already, we have a dedicated imaging people both in the Echo Lab, so Dr. Mamenia and Dr. Atkins in the thoracic radiology, who really have made a lot of this possible. So there are some pictures of our team from different events and training. So you guys, I'm sure, have seen most of these people. I do want to acknowledge the team that works primarily on the outpatient side, and so that's the left bottom corner. All of the PH coordinators are there with Aaron. So you usually don't see them on the inpatient service, but they are essential in taking care of these patients in clinic day in and day out. So with that, if you have any questions, I'm happy to take some questions.
If you all want to unmute yourself, or if you want to put it in chat, either way is fine.
It was super clear. No one has any questions. I know Nikki. I know. Yeah, Nikki is on the call as well. Nikki, you can say hi to everyone and wave. If you guys
Hi guys, I'm the inpatient PA.
So.
Nice to virtually meet you all.
Nice to meet you too.
Yeah.
Okay. All right. Well, this is first of the 4 lectures that we're going to have. Cindy did her magic and recorded it, so this will be available for recording for the CVICU, CTU North, CVSD, and let's see. I guess that's it, right? Staff.
Yeah, I can put it on Canvas accounts. And for those of you who don't have Canvas accounts, if anybody's more technologically savvy than I am, I'm open to suggestions for how to transmit it, because I know emailing it's probably not an option, but I'm sure we can find something.
Yeah, it's a big talk. It's like I could not email it, so
yeah. No.
So our next lecture is going to be there are 3 more lectures. One of them is going to be on PTE, and Dr. Tang is going to tell you all about it and show you really cool pictures. Dr. Boutros and Dr. Tirani, I think either both of them or as a team or one of them is going to do a lecture on balloon pulmonary angioplasty. And then Dr. King is going to do a lecture on management of CTEPH patients after surgery and also right heart failure management as well. So that should be, I think, a very useful and cool lecture as well. So we will get all of them recorded and then figure out how to make it available to everyone.
Okay. Thank you so much, Dr. Schleben. This was really good.
Okay.
Dr. Schleben, I'm one of the nurses on CVICU. My name is Kim Keller. I really appreciate you and the whole team putting these on for us.
Oh, sure.
Yeah. We may not need to know every single finer detail, but it really does help us to kind of understand the patients when they come to us and kind of have a bigger picture understanding. So we really appreciate this.
Oh, great, great. Well, we will figure out how to get this to people, because you know, obviously it's very difficult to get everyone together at the same time, and so people can just kind of look at it at their own convenience and their own time. But yes, no, thank you so much. You guys already have taken care of our first cohort of patients. Have done very well. So I really appreciate all of your help. So the whole team does.
All right. Thank you so much.